Hi everyone, my name's Alex. I'm one of the bariatric nurse practitioners here at Southmead Hospital. We thought we'd do a nice video session just to help you understand bariatric surgery and what's involved and things to start thinking about now before you make your decision about whether it's right to go forward for surgery or not. So a few things we're going to go through with this video is just meet the team, the different kind of procedures that we offer here at North Bristol Trust, the pre-operative diet, because that can be really confusing. Lots of our patients look on the internet and there's just so much information that it's just mind-boggling. So we'll go through that information. What to expect on the day of surgery, the kind of medications. Some of you may be thinking that actually you're on certain medications, you're concerned about them getting changed, so we can go through that. The post-operative diet, follow-up and group sessions, frequently asked questions and what happens next. So some of our team, we're very lucky, we've got 4 consultant surgeons at North Bristol Trust, 4 anaesthetists that are dedicated to bariatric surgery. Myself, we've got a couple of practitioners and dietitians, and we've also got a psychology team, so we're very lucky. So first of all, this is Mr. Hughes. He's just going to talk you through what operations we do here at North Bristol Trust, and then we'll go into them a bit more.
Hi, so my name's Jim Hughes. I'm one of the bariatric surgeons here today, and I thought it would be interesting for us to speak about the different operations that we offer here at North Bristol. They really fall into 3 main categories, 3 different operations that we do. We do them here and it's the same across the whole of the country. The first operation is a gastric band. That is where a silicone band is placed around the top of the stomach. And that's connected to a thin tube and a port that sits underneath the skin. And that works really by reducing the amount of food that you can eat. So the food goes down into the stomach, you get full very quickly, and then gradually the food will trickle through into the remnant of your stomach, and then you're able to take another mouthful after that. The band can be adjusted by injecting water into the port, or it can be loosened off by withdrawing water from the port. So you'll feel a small metal port underneath the skin that you'll be able to, that's what we use to adjust the band with. The second operation that we do here is a gastric bypass. So that's a more common operation that we do here. It's been around 20 years or so. And that involves removing or dissecting a portion of the stomach from the top, from the top of the stomach really, and joining a bit of the intestine up to that. And then there's a further join done lower down. So you'll be able to see a picture of this in the information that we're giving you. And that works in a very different way. So your stomach is much smaller than before, but nothing's been removed, so that everything is still in place, it's just disconnected from the top. So if your stomach's smaller, you can't eat as much, so you get full very quickly. But also, it works in lots of different ways to allow you to lose weight. So this operation's been around for a long period of time, and we know that it does work, it's just that we've not really known until quite recently how it works. And we think the main mechanism is it changes your hunger, so you're not as hungry as before surgery. Also, it changes the signals from your body to your brain, so that your body almost wants to be lighter. And it also has other effects with nerve signals and also the bacteria within your gut. And all of those things together work so that your body wants to be lighter, and therefore you lose weight that way. The third operation is called a sleeve gastrectomy. Now that's been around about 10 years or so, and that you'll again be able to see with the picture in the information. In this operation we staple off and remove about 80% of your stomach, so you're just left with a thin tube, and that works again by reducing the amount of food you can eat, so you can't get as much in. But it has much the same effects as a gastric bypass in changing your hunger and really making your body want to be lighter. So they're the 3 different operations that we offer here. The gastric band and the gastric bypass are reversible, so we can undo them if required. We prefer not to, but the band can be removed and the bypass can be reversed because nothing's taken away from the stomach. The sleeve gastrectomy is completely irreversible. That can't be undone because the stomach is removed. The operations themselves are all general anaesthetic, so you put to sleep. They're all keyhole operations, so that means you have 5 cuts on the front of the tummy, between the tummy button and the top, all about 1 inch long. And we put in instruments and cameras through those ports, and then we do the operations that way. So all the cuts are in exactly the same place. So if I was to look at somebody from the outside, I wouldn't know what operation they've had done because the scars are all in the same place. Whenever we do any keyhole surgery, we've always got to warn the patients about the risks that we may not be able to complete the operation keyhole. And sometimes people need a cut straight up and down, a larger cut to complete with the operation. The operations take different periods of time, so the band is the quickest and most easiest operation. That takes about half an hour to put the band in. The bypass takes about 1.5 hours, and the sleeve gastrectomy takes about 1 hour of operating to do the case. There's a bit of time putting you to sleep and time waking you up after the operation, so generally you're away for about 2 hours from the preoperative room. After the operation, patients with a gastric band are generally day case, so they go home the same day. The bypass and the sleeve patients most of the time go home the next day, so they're usually in hospital for overnight, and we check up on patients in the morning, and most patients go home the next day. Occasionally patients need an extra night or 2 in hospital depending on how well they recover and how mobile they are after surgery. So that really summarises the operations, and please feel free to look through the information booklet so you can find some more information about it at that stage.
So I hope that helps slightly, just to give you some understanding of the different operations. So this kind of page kind of goes through the different operations. So the top left is a gastric bypass, top right is the gastric band, bottom left is a sleeve gastrectomy, and then the bottom right is a gastric balloon. I think I said that right. So the gastric balloon we didn't really talk about because it's one of those things that we only offer to patients that have a BMI of above 60 or kind of hold all their weight in the centre. So the gastric balloon we pop in under general anaesthetic, and then we leave it in for about 6 months, and then we normally go on to do another procedure. So it's something to think about, so keep your options open of what you're thinking, but your surgeon will go through that at the end. So on the gastric bypass part of it, a lot of people look at this and think, oh my goodness, that looks really scary. It's got all these different joints and all these different cuts. But obviously it's the most common procedure we do at North Bristol Trust. This is mainly people, if you've got reflux, this is really useful. I'm starting to do that for patients with reflux. So it's something to think about. If you've had lots of different operations in the past, especially on your tummy, your surgeon may say to you at your appointment that actually it may not be possible to do this operation, because obviously you can see we have to bring the bowel all the way up to the top of your esophagus, and that can be quite difficult if you've got a lot of scar tissue further down. The bottom left is the sleeve gastrectomy. So we take about 80% of your stomach, and we leave about 20% there. So if you have got kind of reflux, this isn't kind of the best operation for you. Obviously you can see we're making it a lot smaller, so therefore it can kind of increase the pressure. But that's again a popular operation. The top right is the gastric band. So as you can see, you've got that little tube that comes down, that sits on kind of just underneath the skin on your abdomen. And then we can put water into that to kind of inflate it, so it kind of increases the pressure, and we can kind of take fluid out, which kind of decreases the fluid. So that's another popular operation. So you can kind of have an idea. And obviously you've got the booklets that we sent you in the post. So hopefully this will give you kind of a bit of a broader range of ideas of what to expect. So this is Mr. Osborne. He's just going to talk you through the complications and the risk factors to think about when you're going forward for surgery.
Hello and welcome. My name is Alan Osborne, one of the bariatric surgeons, and it's a great pleasure to meet you today. I have been asked to talk to you about the risks and benefits of bariatric or weight loss surgery for yourself. Normally that starts by a conversation about you and your past medical history, about how that might affect your individual risk for surgery. We then try and put that into the context of the 3 different operations that we commonly perform, and how those operations have slightly different risks and benefits, and how we might best choose the operation for you, or at least give you the choice to decide on which one has the least risks and greatest benefits for you as an individual. So this would start with a simple conversation about you and your medical history. I obviously need to know The simple facts, such as whether you're a male or a female, how old you are, and how heavy you are. So, for example, we know the most difficult people to operate on are heavy male diabetics. They therefore have the increased risk of any surgery they might choose, however, this may need to be balanced against increased benefits for them. So I sit down with you and we have a really nice conversation in outpatients about your simple demographics that we've discussed, and then your past medical history, such as we've discussed, whether you might be diabetic or anything else that's happened to you in the past that might affect your risk for surgery going forward. Common problems that you might be suffering from might include high blood pressure, high cholesterol, sleep apnea, or even slightly more rare problems such as benign intracranial hypertension. I then go into a detailed medication history, as we need to know every single one of the drugs you might be taking, and of course whether you might be allergic to any medications. The medications are important, as some of them again increase your risk of surgery. Any medication or drug that makes you more likely to bleed, we need to consider the risks and benefits of continuing that in the operative period. Sometimes we stop them, sometimes we continue them, but this sort of thing is something that needs to be carefully discussed with you. From a social history point of view, I need to know whether or not you smoke or drink alcohol. Again, we know that people that smoke are at increased risk of problems when they undergo surgery, and indeed regularly drinking alcohol has been shown to lead to a higher chance for poor outcome in the long term. So we'll discuss all these factors with you. We are going to be operating on your stomach, and so it's important for us to know if you have any symptoms or problems related to your stomach, the most common one of which is reflux. Patients with reflux can find that it can get better or indeed worse after bariatric or weight loss surgery, and this again can be influenced by the type of operations that you have. So we'll take a detailed past medical history, drug history and social history so that we can advise you on how you can reduce your risk of surgery and get the most benefit out of it, and of course to make sure that we perform it safely. As we're going to be operating on you, I need to know about all of your previous operations on your abdomen and especially your stomach, the area we'll be operating on. Any previous surgeries can cause scar tissue or lead to change on the inside, which can make our operations more risky and difficult. And indeed, if you have had certain types of surgery or a lot of operations, then some of our bariatric procedures, such as the gastric bypass, may not be possible to do, as we cannot move the small bowel loops around. So after carefully considering you as an individual, we try and produce an individualised risk for you of really undergoing any operation. Certain things that we've talked about, being male, being heavier, being diabetic, or indeed being on medication that makes you bleed or having a risk of blood clots, some of these things do make surgery very high risk for you. So we'll have that conversation with you and try and minimise any possible chance of any problems as much as possible. So now we consider the 3 different operations for you, and indeed how you as an individual try and help you decide which one might be the best operation for you, with the least risk for you and give you the greatest benefit. So the gastric band is historically the most common operation that was performed, which, as you know, is placing a band around the top of your stomach. With all of the bariatric or weight loss operations, there are the risks of bleeding, pain and infection. However, the gastric band is commonly performed as a day case, and indeed we send you home after you've woken up from the anaesthetic once we know you're well. If we do everything we can to prevent infection getting into your gastric band, including giving you antibiotics on the day, but if infection does get into your gastric band, that is a serious problem that can lead to us having to remove your band in the short term if the usual treatments don't work. So we're very careful to reduce the risk of bleeding, pain or infection for you. In the longer term, the gastric band does have a reoperation rate, so between 1/3 and 50% of people will need us to reoperate on their gastric band, and sometimes that means completely removing your gastric band. And this is due to the bands getting scar tissue around them, eroding or indeed slippage of the gastric band. Sometimes we can reoperate and try and fix the problem and prolong the life span of your gastric band, but at other times we have to remove the band. If we consider the other 2 operations, the gastric bypass and the sleeve gastrectomy, the bypass, as you know, is where we bypass your stomach by creating a small gastric pouch about the size of your thumb and using 2 joins in the small bowel to bypass the stomach. Again, you have the risk of bleeding, of any more major keyhole or laparoscopic surgery. or you can get leakage causing infection from the two joints. Those are the most serious common complications that we worry about and monitor you closely for during your 23-hour stay. If you do have a sign of bleeding or leakage, we might need to re-operate on you, and it is rare that this is performed with keyhole or laparoscopic surgery. I might need to convert to open surgery, which is a big cut to open up the whole of your abdomen. Commonly, we can fix the problem, but this results in a prolonged hospital stay with the usual risks and complications of this, such as blood clots or a chest infection. Again, we do everything we can to reduce the risk of this with antibiotics and indeed injections to reduce the risk of blood clots. This is why we have to carefully consider all the different operations for you. The other one is the sleeve gastrectomy, where we remove 80% or the majority of the stomach, and there can be leakage from the staple line, again causing infection and again requiring the need for conversion to open surgery in a prolonged hospital stay. So these are significant operations with the normal risks of any major surgery of bleeding, pain and infection. And in the longer term, as well as the gastric band, both the sleeve and the bypass do have a reoperation rate, which varies in the literature, the evidence suggesting it could be between 10% and 30%, so maybe up to a third of people, even after a bypass or a sleeve, may need a reoperation. And this can be because of ulceration, narrowing of the bypass or sleeve, causing symptoms suggestive of a blockage of the bowel or worsening of reflux. So again, all these will be explained to you in detail when you sign your consent form. I hope this has been helpful, and I look forward to meeting you in person.
So obviously that can sound really, really scary, can't it? That actually all these risks that you're going to put yourself forward for. But just to break it down kind of really basic for you. So obviously normal risks that you get for any operation, obviously blood clots, but we obviously give you injections and we obviously get you to mobilise as much as possible. Wound infection, very, 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 very slim chance. Gastric band slipping out of place, obviously you're putting something into your body, so obviously you can always move. Leak in the gut, so where we saw that those joins and those staple lines, sometimes you can see that actually those don't quite join nicely enough, and sometimes you can get a bit of leakage from that. A blocked gut, malnutrition, gallstones and risk of dying is at the bottom, and we do that because obviously it's very, very slim chance of risk of dying. So the next surgeon is Mr. Panaras. He's just going to speak to you about how the surgery actually works, and a bit about obesity.
Welcome to North Bristol. I'm Dimitri Panaras. I am a member of the multidisciplinary team in the weight loss management service, and I work as a surgeon. The sign outside says weight loss surgeon, but what I really do is health gain surgery. The question I often get asked is how these procedures work. And to understand the mechanism of these operations, one has to understand how we all eat and how our appetite works. I had breakfast this morning and at some point I stopped eating. And I often verbalized as that my stomach was full. But that is not true, because if you gave me a litre of water, or even better, a latte, I'll be able to drink it and my stomach will not explode. The reason I stopped eating was because there was a message from my gut to my brain that told me to do so. And that part of the brain is in the midbrain. This is different from the outer brain. The outer brain does the analytical thinking and the complex tasks, the medicine or the surgery or whatever work is. The midbrain is the part that also does your breathing. Now you have been breathing all day today and you haven't thought about it until now. You cannot control your breathing. You cannot stop yourself from breathing in the same way that you cannot talk yourself into stop eating. Therefore, obesity as a disease is not your fault. It is just physiology. The treatment options we have at the moment cannot target that part of the brain. We're not refined enough regarding this. But we do have surgical procedures that change the signaling from the gut to the brain. And that's exactly what a laparoscopic sleeve gastrectomy, a laparoscopic MRI gastric bypass and a gastric band do. The operations do not do the weight loss. You do the weight loss. The procedures help you achieve weight loss maintenance. And they don't work alone. The combination of behavioral modifications, dietetic support, pharmacotherapy in the form of tablets and medication, psychological support, and surgery together will achieve that goal. And the goal is not weight loss. The goal is health gain, is improvement in quality of life and improvement in survival, a longer life. These surgical procedures have a profound effect on a number of diseases associated with obesity, such as diabetes, obstructive sleep apnea, hypertension, gastroesophageal reflux disease. Very often this effect is due to weight loss, but there is also effect for some of them which is beyond weight loss. Ultimately, these procedures allow you to live a longer and a better quality of life. I'm looking forward to meeting you during this long journey.
So I hope that kind of helps you understand a bit more about how surgery works. So we'll go on to Mr. Hopkins' video now. So he's going to talk to you about complications, and that's the surgeon's done.
Hello, my name's James Hopkins. I'm one of the bariatric surgeons here in the unit, and I'm here to talk to you today about complications of surgery. Now, it is very important that you understand this because you'll be asked to sign a consent form for your operation, and you have to understand the risks of the surgery itself to be able to do this. But what I want to say is, please don't be frightened by all the different things I'm telling you, because overall, our operations are remarkably safe. In fact, most people would not think twice about having their gallbladder out by keyhole surgery, and the overall risks of our weight loss surgery is exactly the same as a keyhole gallbladder operation. Now, there are those risks which happen with any type of surgery, no matter what the operation is. And those are things like bleeding, infection and wound problems, and everyone gets some pain and discomfort after surgery, but these pass very quickly and are very, very manageable. But what I want to tell you about individually is each of the 3 operations that we do and the risks of those types of surgeries. Now, the gastric band is the easiest of the 3 operations we do on the day, and therefore carries the lowest overall risk from having that procedure. In fact, the mortality rate from insertion of a gastric band in this country is 0. However, there are some issues that can occur with gastric band afterwards around the fact that you have an adjustable device, and there can be problems with the port and the tubing which require a minor reoperation to fix, and also occasionally and rarely some problems with the band itself around the stomach where it can slip or even very rarely erode, and that's less than 1 or 2 in 100, and that also requires a reoperation to fix. So overall, for the whole lifetime of the band, about 4 or 5 people per 100 will require a revision surgery. Now, the other 2 operations that we do here are the bypass and the sleeve, and I group these together as stapling operations because of the technique that we use during the surgery itself. This makes the operations a little bit more complicated on the day, and there is an increased risk from either leaks, bleeding or infection around those staple lines in the joints that we make, and that will almost certainly require a reoperation to treat, and that happens in around 1 or 2 per 100 of the cases that we do. Now, once you have had your bypass or sleeve operation, the rates of getting complication requiring an operation after that for the rest of the lifetime of the operation are less than a band, but overall, if you add up the numbers together, the total is about 4 or 5 per 100, i.e. it's about the same as the band. However, because the bypass and the sleeve are a little bit more complicated on the day that we do it, and the complications can be harder to manage, a leak, for example, there is a small mortality rate attached to the operation of around 1 in 500 to 1 in 1,000. Now, the final thing I want to tell you about in relation to any weight loss surgery is the nutritional issues for the long term. What we advise is you take your multivitamin and mineral supplements every day for the rest of your life. And it is vital you do that because it can prevent some very, very hard to treat nutritional deficiencies should they arise. But they are so easy to prevent by taking your vitamin and mineral supplements. Now, I'm sure you will have some more questions about the operations themselves, so please feel free to ask any of us at all when you meet us in clinic. May I take this opportunity to wish you all the best, to reassure you that our operations are safe, are simple, are very easy to perform, and you will do very well with whichever operation you choose to have, and good luck for the future.
So that was quite good. I hope that helped again as well. Jeanette's going to talk about the pre-op diet and what to expect, so we'll just let her do a little spiel and then we'll do some more.
So hi, my name's Jeanette. I'm one of the dietitians on the bariatric team, and I'm here today to talk a little bit about the pre-op diet. So some of you may have heard it called the liver reducing diet or a liver shrinking diet, and this isn't some fad weight loss diet that we're putting you on before your surgery. This is to actually improve the safety of your operation. So if you can imagine, you've got your liver sitting on top of your stomach. For quite a lot of us, that liver can be quite large and heavy. It stores a lot of our carbohydrates, some fats, and a lot of water. And if it's sitting there very heavy on top of your stomach, it's very difficult for your surgeon to get in and do anything to your stomach underneath. So what we need to do is work out a way to shrink this down and make the operation a lot safer. And the way that we do that is that we have a specially designed 2-week pre-op diet to manage this. If you aren't able to do that and your liver remains too large, there is a risk that the surgeon may not be able to actually do that operation. So it is really important that you do follow this. And there are different ways that we can reduce the liver down, and they're all aimed at reducing the carbohydrate content of your diet and reducing the fat content, and it's very low calorie so that we use up our stores and it shrinks down. So one of the first ways that we can do it is by using meal replacement shakes. Some of you may have used those before. It's not something that we recommend to use in the long term, but for 2 weeks before your surgery, they can be used to shrink down your liver. So we'd recommend 3 to 4 a day, spread throughout the day, and you can get them from your local chemist or from a supermarket. We do recommend that you try and choose ones that are lower in sugar and carbohydrates so that it works better in reducing your liver down. So that's one option. There's another option. If you prefer to use real food, you can still do that. What we recommend is having between 800 and 1,000 calories a day, but being very careful around the amount of carbohydrates and fat that are in those meals and in those snacks during the day. So what I mean by that is being careful of foods like pasta, rice, bread, your breakfast cereals, things like porridge, couscous, products made with flour, and also any sweet foods, so foods like chocolate and biscuits and cakes, but also the foods that contain those hidden sugars as well, so things like your ketchups, your sauces, salad creams, and any kind of sugary drinks as well. So it's all low on those sorts of foods, but it includes good quality proteins to help keep your muscles up and keep you healthy before surgery, and plenty of vegetables. It's also quite low in fat, so we need to be careful how we cook foods, if we're adding any extra fats to any of the meals that we're having. But there is a really detailed guide on how to follow this. You can also have a mixture of the two, so you can have some shakes and some food, and some people find this helpful if they're kind of working but then want to eat a meal in the evening with their family, so they might have a shake for breakfast, a shake for their lunch in the afternoon, and then come home and have a meal such as like a chicken stir fry or some fish with some steamed vegetables, a boiled egg salad, and so they can feel that they're still eating with people. You just want to be careful there that your main meal in the evening doesn't take you over your overall calorie intake. So those are the 3 main options, and with all of them we suggest that you make sure that you spread all your food, all your shakes throughout the day so that you're getting a constant supply of energy and you're not just having it all in one go. You need to be really careful to make sure that you stay hydrated. Obviously you'll be having a lot less food than you're used to, and we get quite a lot of fluid from that, so you will feel quite a lot thirstier than normal. You just want to be careful of the drinks that you are having. So you can have tea and coffee, just be careful about the amount of milk that you're using. You can either have them black or you can use the milk from the allowance. You can have your kind of sugar-free drinks, and you can have plenty of water, but just watch out for any sugars in them, because that will just be feeding into your liver and making it bigger again. It's also no alcohol. Because obviously that again will contain lots of sugar, and it's not going to make you feel very good when you're eating such low calories either. And so just to warn you about what to expect as well. So in the first few days of following a diet like this, you may feel quite lightheaded, you might feel a bit headachy, but this should pass and things do sometimes get a bit easier. But if you are really struggling in those first few days, do call us. We're there to support you through this. And it is quite common not to feel great to start with. Another thing we need to remember is to take a multivitamin and mineral supplement while you're doing these diets, mainly because they're not going to be meeting your nutritional requirements, and we do want you as healthy as possible when you're going into surgery so that you can heal well afterwards, and that we can make sure that we don't develop any nutrient deficiencies. If you've got diabetes, we do need to be a little bit more careful, so I'd really recommend you grabbing one of the team and discussing that with them, so that we can make sure that we can get you through that time safely. If you've got any worries or any questions, don't hesitate to ask any of us. It can be quite confusing, and if you try and look on the internet, you'll find hundreds and hundreds of different ways to do this, and that can be quite overwhelming. So if you've got any worries, just grab one of us, and we're more than happy to help you through this time. I'm sure I've met some of you before, and I really look forward to seeing you again on your journey. For those who I haven't met, I'm looking forward to seeing you on the other side.
So I hope that's helped some of you understand kind of what's involved in the pre-op diet. So there's a couple of options you can do, like Jeanette said. So the main things to think about is obviously get your water intake every day and think about what works for you. So I were an early riser that actually doesn't have time for breakfast. So maybe actually a shake might be good for you. So start to plan it now. So if you're going to go forward for surgery and the surgeon kind of thinks that you're suitable and we send you a letter, then start to prep and start to think, well, how could I manage this? What could I kind of think about eating? And maybe it might be shakes work better for you, and then maybe an evening meal might work well for you. So just to start thinking about it, and it's not as bad as it thinks, obviously, as you think, sorry. Lots of patients say, actually, do you know what, it really helped get me ready for surgery and kind of reduce my portion sizes, and really, yeah, it just helps a lot of patients. So as long as there's no sauces, no hidden carbohydrates, anything, then you'll find kind of eat what we recommend. And we'll obviously, in the booklet we've given you, there's also a really good guide in there, so that'd be helpful as well. So try and have a look at that as well. Then also just to think about your liver. A lot of people with obesity have really fatty livers. So you imagine that liver being really fatty, and it's really hard for that surgeon to lift it up. So this isn't about weight loss at all. This is just purely about a safety element in your operation. So really think about that when you're doing the diet. Yes, it may be difficult for you, but really think about, actually, I really want to be safe. I want to make sure everything goes okay in the operation. And we have had patients, unfortunately, that we've opened them up and we've tried to do the operation and their liver's been too big. And we can tell if you haven't followed the diet. It's quite clear the liver looks very different when you followed a really kind of low carbohydrate diet. So please, please, please don't waste anyone's time, and please make sure that you follow the diet, all right? So this is Jill, our anaesthetist. She's amazing. She's one of our lead anaesthetists that works in our bariatric team. So she's going to talk to you about how to get yourself ready and what to expect.
Hello, my name is Dr. Jill Homewood, and I'm an anaesthetic consultant working at Southmead Hospital with an interest in bariatric surgery. Anaesthetists are medical doctors whose role is to assess your fitness for surgery and anaesthetic, to keep you safe and asleep during the operation, and to make sure you have good pain relief afterwards. Before your operation, you'll be invited to come to a pre-operative assessment clinic. This is an important part of the process. Here, nurses will ask you a number of questions about previous operations you may have and assess your general fitness for surgery. They will take some routine measurements of your height and weight, blood pressure and oxygen levels and so forth. They'll also perform routine electrical heart tracings and take blood tests. If they feel you need it, they will also ask for you to be seen by an anaesthetic doctor in the clinic. They may ask you some more questions, and if need be, refer you on for further investigations or tests to make sure that your surgery is as safe as possible for you. You'll also see a pharmacist in the clinic. They will look at any medication that you take currently and make a plan for how that will be managed around the time of surgery. Some of you will have a diagnosis of sleep apnea, and you may already use a CPAP machine. If you do have this, please try and use it as often as you can before the time of surgery and bring it into hospital when you come for your operation. This is really important as we use it in hospital. It's also very important, if you can, to increase the amount of exercise that you take, even by small amounts, in the time leading up to surgery. We know that this does make a real difference to how quickly you recover from the operation. On the day of surgery, you will have been given instructions as when to stop eating and drinking, and you'll come into an area called the Medi Rooms. Here you'll be welcomed by a nurse who will check you in and make sure that nothing has changed since you were seen in the clinic. You'll also be seen by the anaesthetist who's with you on the day and the surgeon before you go to the operation. This will give you the opportunity to answer any more questions, ask any more questions that you have. You may have a drip placed when you're in the Medi Rooms, and you will walk to the operating theatre. Here, final checks will be done, and you'll be encouraged to get onto the operating table and be in a comfortable position before the surgery starts. We will attach monitoring to you, which helps us keep an eye on you whilst you're asleep, and the anaesthetic will all be administered through the drip. You'll be given some oxygen to breathe before you go off to sleep. When the operation has finished, we stop the anaesthetic and you wake up in the operating theatre on the table. It's important for you to get up and about and moving as soon as possible after your operation, and many patients are actually able to move themselves from the operating table into the bed after their operation. If you find this difficult, we can help you with this. You'll then return to the Medi Room area, where the nurses will continue to observe you and give you any pain medication or anti-sickness medication you may need. It is normal to feel some discomfort after surgery. This soreness often feels like indigestion or wind-type pain, and it usually settles quite quickly within the first few hours of surgery. Everybody needs a different amount of pain medicine, and we will give you what you need, but there is a balance to be made between the amount of pain medicine you have and the side effects that it can sometimes have of making you just feel more sleepy and sometimes more sick. Most patients are actually able to get up and out of bed and walk to the toilet within 4 hours of surgery. After you've spent some time in the recovery area, you will return to a ward area, and there you'll continue to have medicine as you need regularly for pain relief and sickness. Most patients are able to go home on the day following surgery if everything is straightforward and goes well. We're looking forward to meeting you and hope everything goes well in the time leading up to surgery. Thank you.
So again, I hope that was helpful for you. It gives you kind of an idea. And our anaesthetist is so experienced with managing patients with obesity and during this process. So hopefully you'll find it useful. So what to kind of expect on the day of surgery? So we weigh you first of all, just to make sure how your weight's doing and how you're managing. And it's just a point there to make sure that when you see me in pre-op, when you see the surgeon, we want it to be the same weight. So just try to keep an eye on the weight. We don't need to necessarily come down massively, but we just want to see it stabilised or maintained. We try and put a needle in your hand or your arm and take some bloods off of you. You get seen by the surgeon, the anaesthetist, and a team, so it just kind of helps you understand and answer any questions you may have. We can send you to the theatre and go through all the risks, but you may have received the consent form already in the post, so we can just go back over any questions. We get you to walk to theatre just to help things, and we only keep you in for one night. We try and discharge you at 7:30 in the morning the next day. And that can be quite a surprise for people, because a lot of people think, oh, I just want to have a bit of a respite period, away from the family, away from the kids. But it's really important that we get you home as soon as possible, back to your normal environment, where you're drinking what fluids you like, so your own tea, your own coffee, your own squash and water. So it's really beneficial. You'll be, well, some of you might be pleased, some of you may not be. We get you up as soon as possible, okay? So really, really important. You're going to have some discomfort, you're going to have some pain, like Jill said, but really important to get rid of that gas, mobilise as soon as you can. And then we get you drinking sips of water straight away, all right? So just think about those things. So this is Danielle. She's one of our specialist bariatric pharmacists. We're very lucky to have her in our team. So she will see you in pre-op assessment, and she'll go through all your medications and make sure they're all okay. And she'll change some things if she needs to change them. And on the day of surgery, she'll come and see you as well to go through medication. So common medications started after surgery. So this is kind of a list of what we give you. So we give you enoxaparin injection. So we make you do them yourself. So it's just for 14 days after the operation, just to prevent blood clots. We give you a lansoprazole tablet once a day. We normally keep you on it for about 3 months. Some of you may be on a metrazole, some of you may be on other medications, but we can convert you to that. It just goes underneath your tongue or on your tongue. We give you an anti-sickness that we get you to take 3 times a day. Many people don't feel that sick after surgery, but we just put it in there just as you need it. Then the next 3 are your lifelong multivitamins, all right? So we've got your calcium and vitamin D, which is really important. So you'll hear us talk a lot about multivitamins. So this one is your lifelong, so you take it twice a day. It comes in a sachet, or it can come in a tablet that you can chew. We give you iron liquid, and that's just once a day. It's not the nicest, but a lot of people kind of just have to take it. And then you go into tablets, and then we ask you to buy your own chewable and multivitamin, and that's again for the rest of your life, and that's just once a day, but you can buy it yourself. So this is David. He's one of our practitioners, and he's just going to go through the post-op diet and what to expect.
Hello, my name's David, and I'm a bariatric practitioner and dietitian working for the bariatric surgery team. I've been asked to introduce 3 key topics to you today that's in relation to the nutritional management following bariatric surgery. Now, the first topic is the post-operative diet. The post-operative diet is essentially a texture-modified diet, manipulating the textures of the patient's diet from day 1 post-op to 4 weeks post-op. So this is introducing liquids only for the first week to 2 weeks following bariatric surgery, then progressing the textures to more pureed foods, then to more mashed foods, and then by week 4 patients should be on a normal textured diet. The volumes will change during this time, and patients will find that they're able to tolerate larger volumes as time goes on following surgery, and this is due to the inflammation reducing following bariatric surgery, and just generally the recovery and the healing process following the surgical procedure allows the patient to increase the volumes of what they can consume during the texture modified diet to increase with time. The second topic that I've been asked to discuss is hydration. Now, hydration is usually something that patients don't usually think about before bariatric surgery. However, after, we see that a lot of patients struggle to meet their hydrational needs per day. Patients will find it difficult to begin with for exactly the same reasons: the inflammation and the recovery and the healing process following the surgical procedure. Patients will find it difficult to drink the volumes that they need, and this will typically get easier with time. So, for example, patients will find it very difficult to drink, for example, 150 to 200 mils in one sitting after bariatric surgery. However, usually 4-5 weeks, maybe even a couple of months after surgery, this tends to get a bit easier. So patients, for example, will describe that they're only able to sip and rather than gulp fluid. With that in mind, what we tend to advise patients is to drink little and often, to keep a sports bottle with them or just a general water bottle with them, that they're going to just keep topping up their hydration to meet their hydrational needs. The last topic I've been asked to discuss is the supplementation aspect following bariatric surgery, and I'm mainly going to focus on the vitamin and mineral supplementation following bariatric surgery. Now, these vitamin and minerals are collectively known as micronutrients. So if you hear your healthcare professional mentioning the word micronutrients, essentially that means vitamins and minerals. They mean exactly the same thing. Now, these are these compounds, these nutrients are important for general health, but also they have a part to play in the healing process and the recovery following bariatric surgery. For example, wound healing. Vitamins and minerals are very important for the general population, but for bariatric surgery patients even more so, because by altering the gastrointestinal tract, you're essentially altering how these nutrients are absorbed. And typically patients are not managing the same volumes of foods and fluids that they were taking pre-operatively. Therefore, the amount of goodness that they get from their food is significantly reduced. So we supplement. These supplements will differ, and the amount of supplements will differ for each surgical procedure. But to give you an example, the sleeve and the bypass patients will require up to 6 oral tablets a day. Now, if you're a patient that's not used to taking oral tablets or medications per day, this might be something you want to think about preoperatively with regards to how you remind yourself where you need to keep them, to take them on a daily basis to ensure your nutritional health. In addition, a lot of our patients will require vitamin B12 injections, and that would be undertaken at their GP practice on a 3-monthly basis. So these are potentially logistical issues that you'll need to think about post-surgery to maintain that nutritional health and to maintain your vitamin and mineral status following bariatric surgery. Of course, we'd like to wish you all the best in your pathway with the bariatric surgery team, and we look forward to seeing you on the post-operative journey.
So I hope that you all find that kind of helpful. So that gives you an idea. A lot of people think they're going to be on broth for kind of weeks and weeks and weeks, but it gives you an idea of what to expect. So we start you off on just sips of fluid, and then we build you up really slowly to a liquid diet, and then we kind of get you on a more of a textured diet. But again, it's a bit more information in your booklet that you have. So things to start thinking about. So we kind of ask patients to start thinking about the portion sizes. So obviously your food intake, if you go forward for bariatric surgery, will be dramatically reduced. So really important to start thinking about this. So start to leave food on your plate now. And think about the quality of food. So a lot of patients can only eat small amounts of food after surgery. So think about what quality of meats could you get? What kind of protein could you get? What kind of vegetarian option can you get? So it's really important to think about that. You don't necessarily need to go and think about, you don't need to go and buy like specific kind of like plates or cutlery, but just start to think about the smaller plates, any teacups, any side plates are always useful. Some foods will be a lot easier to eat and you can eat more of them. So you'll find that actually some soup maybe go down a lot easier than maybe a bit of a chicken breast or some mince. So just you'll notice that as you go along. And obviously some foods you might be intolerant to. So some patients will say, I really can't tolerate, say, chicken or some of the drier meats. So like pork, beef, that can be quite difficult for a lot of patients. And obviously chewing is really important, unfortunately, for bariatric patients. So we try and get you to chew your food at least 20 times. Obviously not the soups, because that's obviously quite difficult. But yeah, it can be quite difficult. So just, again, start to try and do that now. And obviously just think at the bottom, which one's the largest portion? A lot of patients kind of look and go, oh, I have a kind of a small side plate and you piled it high and it looks really big. Whereas if you had a really big plate and only put a small amount or the same amount on, it would look a lot smaller. So they're actually exactly the same size. And then planning is really key for kind of staying healthy and kind of getting the results that you want. So 3 meals ideally a day and at least 2 to 3 high protein snacks. Because obviously your 3 meals are going to be a lot more reduced compared to the size you're eating now maybe. Try not to leave the house without a drink or a snack. Really important that you'll find, especially fluid-wise, it's really important to hydrate yourself continually. You won't be able to gulp loads and loads of fluids all the time, so really important that actually you have sips continually. And obviously multivitamins we've gone through, which you'll hear a lot. And obviously 3 monthly injections you have to have at your GP practice. Don't miss a meal, really important. And obviously no alcohol. We say for about 3 to 6 months ideally, because some people find that it seems to get a little bit easier than food sometimes. So we try and keep you away from that until you've got your food routine up together. The next slide talks about pacing. So it's important to go at your own pace. There'll be some people that you know that have lost weight really quickly or have had surgery that have done amazing and some people haven't. So just focus on your own pathway and then you'll do well. Obviously the 20-20-20-20 rule, some of you may have heard of that in our tier 3 weight management service. Obviously 20 minutes, 20 chews, 20 seconds, and then 20 minutes. If your food hasn't gone, then get rid of it. Sipping water we've talked about, and then you'll be shocked, some of you might be, no fizzy drinks are allowed. The bubbles can cause lots of problems, whatever surgery you have, so we say not to avoid fizzy drinks. So if you're someone that really enjoys fizzy drinks now, start to think about how you may be able to wean yourself off of them and maybe go to water and squashes. And obviously it's not very easy for a lot of people. Try and avoid just weighing yourself more than once a week. Lots of patients after surgery will just get rid of their scales and just really just focus on the weight when they come and see us in hospital. And then the last piece, thinking about picking. So a lot of people will kind of say afterwards that the picking strategies change. So it can be kind of boredom, it can be stress, it can be thirsty, it can be, I'm actually hungry, but I'm used to, at 3 o'clock, I'm used to having a biscuit all the time. So again, just start to think, actually, do I reach for the cupboards? Do I go in the fridge? Because that can really help you going forward. And it might be that actually you go, okay, instead of having something to eat, I might turn around and go, I need to go for a walk. And just be aware that taste can change quite a lot. So lots of patients will say afterwards that their taste really changes. So we've had people that have really been tea lovers and hated coffee, and then they've switched and become obsessed with coffee, and then they don't like tea anymore. So if you're someone that really has to have something, say coffee drinking, you have kind of 10 cups a day, think about maybe reducing that and seeing what other things you like. So we're just going to go through this one. So this is about goals. It's something that our psychology team wanted us to put in this video because I think it's really useful to start thinking about it. So how did you manage difficult situations? So thinking about surgery, how do you manage them? Do you find that you turn to food? Do you find that you turn to friends? Do you turn to family? So it's something to start thinking about. What do you think will be different after you have surgery? Do you think that your life will dramatically change? Do you think that you're going to get a new job? Your self-esteem will be different? And who will help or hinder you achieve your goals? Do you think that actually your partner will be supportive or your friends will be supportive? We have had relationships break down after surgery, and we have had friendships change. And also just to start thinking about how can you get to some of your goals. So it may be that your goals are there and actually you're not quite sure of how to get to them. So maybe just write them down and say, well, what do I want to do? Why do I want to have bariatric surgery? Is it because I want to be able to walk to school to my children? Do I want to go swimming with my children? Do I want to go out with friends and family? And obviously goals and motivation can change throughout. So try and put yourself on this timeline and think about where you fit in this kind of goals. And next, expectations of surgery. So bariatric surgery can have a huge, amazing impact on people. However, it can be really challenging and you can get some really unexpected emotions. And just to start to think about how will it change your life? How will it impact you? Also, who's going to support you? It's always useful to have that support from friends, from family, from neighbours, from other people that have gone through the experience. And who's going to struggle with this change? If you go forward for surgery, is there anyone that's going to really struggle with you having this surgery and seeing you on weight loss? That can be a battle for a lot of people. And also start to think about your body. How's it going to change? Will you get loose skin? How are you going to cope if you have scars on your tummy? Will you have the support from other people from this? A lot of people can experience pain physically and emotionally. It can be quite a challenge for some people. And please remember that it doesn't always improve your life and all aspects. So it doesn't always improve your appearance, doesn't always improve your mood. So for someone that may have depression, it may not always improve that. So don't always go into this thinking that it's going to have a positive impact, because it can have a few negative impacts as well. And then just to talk about the follow-up we offer of bariatric surgery. So you get to see myself at 4 weeks. You then see a dietitian about 3 months, 6 months, 9 months and 12 months, and then at 24 months. And we're going to hopefully try and start offering group sessions again. And then just some frequently asked questions. So a lot of people just kind of ask me about how long will I be off work? I normally say to people, depending on your job, it's normally 2 to 4 weeks. Driving, always contact your insurance company. That's really important, but most people can drive after a couple of weeks. As long as you can do emergency stop, you're fine. When I have many scars after surgery, so you have 5 little scars, but obviously be aware that you may have a big scar if you need to have open surgery. Exercising, we say about 6 weeks after surgery. Excess skin will really vary from patient to patient. Alcohol we've touched on, and sometimes you can lose your hair. Only small amounts, it's not huge amounts, but it's something to be aware of. And then lastly, what happens next? So you'll get your surgeon appointment through the post, and hopefully after this video and going through the booklet, you'll have an idea of what operation you want to have and what the things you're thinking of, and gone through some of those questions. And obviously you can rewatch this video as many times as you want to, and it will hopefully just help guide some of those uneasy feelings you may have or uncertainty you may have about surgery. Once the surgeon's seen you and gone through the operations with you and talked about what you're suitable for, he'll then take you to our MDT, or so our multidisciplinary team meeting. We'll all have a discussion about you, and then we'll decide whether we think it's suitable for you to have surgery. You'll then come and see me at pre-op assessment, where we'll go through any questions you may have following this video, or any booklet or questions you may have from the surgeon that you maybe don't want to ask them. And we'll go through this in detail. So it just so write your questions down after today, and then we can go through them. We'll also check your weight at that appointment, and you'll get your surgery date at that appointment as well. Sorry. So again, your weight, as we talked about earlier, from your surgeon appointment, your weight needs to be stable for when I see you in clinic. Obviously, you'll get a surgery date then, and then you'll go on to see your pre-op assessment clinic, and then you'll see a pharmacist, anaesthetist, and you'll see the nurses there. And then the next step is surgery, which is really exciting for a lot of people. So as I said, any questions you have, I know that I'm sure there's be a few of them, please just jot them down and write them down after this video session. And then when you come and see me in pre-op assessment, bring them with you, and we can go through them. I hope this has been helpful, and I look forward to seeing you all very, very soon. All right, have a good rest of your day.